Thank you everybody for joining in. I already can see there are nearly 60 people here. This is extremely encouraging. What we will do is essentially basically take you through the physiological basis of one lung ventilation, and then uh, possibly then take a break, maybe look at questions, and finally uh, go through the management bit of one lung anesthesia. What you see is lung volumes and gas exchange during anesthesia. What we will try and do is take you finally through gas exchange through anesthesia. Okay, so what general anesthesia does to the physiology of breathing, if you want to see, it affects both the static as well as the dynamic behaviors. By the static, we mean the pressure volume relationship, and as well as the dynamic behaviors like the pressure flow behaviors. So that's what general anesthesia does to the physiology of breathing. Uh, Coming to the main thing that anesthesia does is the moment you anesthetized a person who's already supine, the FRC, or the functional residual capacity, reduces by 15 to 20% of the awake value. Remember, the same change happens the moment a person is erect and then becomes recumbent. The FRC goes down by 15 to 20%. And this recumbent patient, moment you administered a general anesthetic, it reduces by another 15 to 20%. So this is one of the things that GA does, general anesthesia does to the FRC, and especially to somebody obese, because this is related to age and body habitus. Especially in the morbid habits, this decrease can be up to 50% of the pre-anesthetic values. And so this becomes a real bothersome thing. So what general anesthesia does to the physiology of breathing, this is one of them. So what is the reduced FRC's effect on the airway? So at the high lung volumes, the effect is large, and the low lung volume, it is long, and it can change the caliber of the airway. So, and this is in one way a passive change in the airway resistance, which is independent of airway constriction. So FRC can also affect the the dynamic behavior. The general anesthesia, by the reduction in FRC, can change the dynamic behavior of breathing as well. Okay, so when does this happen? It starts in nearly instantaneously. Reduction occurs within a minute after induction. Fortunately, it does not progress with time unless something else also is happening, or you're doing something else by which the FRC can come down. And it is not, it has been seen by most studies, that not affected by further addition of muscle relaxants. So that is why if you want to reduce this, it has to happen quite early. Okay. So why does the FRC decrease under a general anesthetic? If you look at the main, it's a complex mechanism and it's not totally understood. And the possible mechanisms through which it can happen is through atelectasis, increased expiratory muscle activity, which is coming out emptying the thoracic cavity, the trapping of gas in the distal airways closing, so trapping, so FRC goes down, cephalate displacement of the diaphragm during general anesthesia, decreased outward chest recoil. Remember, there are two recoils: the thoracic cage. There is an outward chest recoil, where there is an inward recoil of the lung, and there is a decreased outward chest recoil, where there is an increased inward recoil of the lung, which is why again you can have decreased FRC. And there could be any reason wherein there is an increased thoracic blood volume. Classically, when you put them to sleep, the thing that is in the limbs are coming into the thorax, and that is how the thoracic blood volume can go down. So those are the reasons by which the FRC could decrease. Is the type of anesthesia, does it influence the reduction of the functional residual capacity? Yes, it is more dramatic and more pronounced with inhalation anesthetics than with intravenous. but it can happen with intravenous, but it is shown to be lower than with inhalation. And it essentially possibly is because the halogenated inhalation agents decreases the tonicity of the diaphragm and the intercostal muscles, which is why it is possibly higher with that. So that little, let's now move out from FRC and look at the mechanics of breathing. So with general anesthesia, what happens to the distribution of ventilation? Essentially, what we will try and do is look at what is happening to ventilation and look at the other part, which is look what is happening to the flow or the vascular component of the physiology of breathing. So let us look first at ventilation. Ventilation per se is not uniform throughout the lung. And why is it not so? Because of this effect of gravity and the shape of this thorax. And because of that, there is a vertical gradient of the pleural pressures. And what do I mean by that? Is that the pleural pressures in the upper or the non-dependent areas is more subatmospheric. That is, it is more negative than what it is in the lower dependent portions. I think all of you know this. And this ultimately leads to that the non-dependent portions are more inflated. This is a classical diagram which explains how this is happening and which kind of tells you that the possibility the lung is a little globular in structure. Through the physiology of the breathing, you'll figure out that the pressure in the airway tract is the same throughout, while the pleural pressures changes, and the gradient between the pressure in the airway, or maybe you can say the pressure in the alveoli minus the pressure in the pleura, determines the distension of the alveoli. So if you look at what is the alveolar gradient, this is what is possibly the one that is causing the distension, and this is what is how it is arrived at. How much do the gradient change? It changes by around 0.4 centimeter of water per centimeter of the lung. So if you look at a lung which is around 30 centimeter in height in the erect posture, the gradient changes by around 7.5 centimeter, which is the pressure difference between the apex to the base. In the supine position, the height of lung reduces by 1/3. So this effect is diminished, but it still exists. And this is important to realize because when we'll talk about one lung ventilation and one lung anesthesia. So how does this pleural pressure gradients actually make a difference? And we talked about this transpulmonary pressure, and how does this transpulmonary pressure or a change in transpulmonary pressure acts as a function to distend the alveoli. Say, because of this gradient, and because whether they are supine, so whatever be the height, so there will be a gradient. For a given transpulmonary pressure during breath, the changes in volume is more in the dependent areas. So you can make out from this graph over here. So if the alveoli is lying over here and there is a change in the transpulmonary gradient, the distending pressure, the change that you obtain will be more than if you are trying to see a change over here. So because of the sigmoid shaped pressure volume curve, the dependent areas are in the steeper part of the slope, and therefore it produces a greater change, unlike in this part of the slope where it is flatter, that there is a lower regional compliance. And so the larger non-dependent areas are in the lower part of the regional compliance, and which is why the less steep portion of the curve. And if you look at this graph, this explains it even better. If you find that, as we talked about, the non-dependent areas are lying in the steep part of the curve, and so the regional compliance is low here. So for a given transpulmonary pressure change, the change in the volume will be much less than in the dependent areas where where the alveoli reside. You'll find they're in the steeper part of the curve, and for a given change in the transpulmonary pressure, the change will be much more. So this is trying to understand how the pleural pressures influence the distension of the alveoli. So you find that there is this alteration of ventilation based upon where the alveoli are positioned in in the given lung complex, and that is how the difference between the kind of changes in the volumes in the dependent areas to the non-dependent areas. Is there any alteration of perfusion as well? I think everybody kind of understand this, that due to the gravitational effects, the dependent or the basal areas are better perfused, while in an awake spontaneously breathing patients, the bases are better ventilated, and this leads to a good matching of ventilation and perfusion. And I think this is again one of the things that everybody goes through as to what is happening with the changes from the top to the bottom of the ribs, and what is happening to ventilation and what is happening to perfusion. You can find that as you go down, the ventilation also increases, the perfusion also increases, but the rate of change of the perfusion is higher than the rate of change in ventilation, which is when you plot the VQ ratio, you find that it is going down as you are progressively going down the ribs. So which essentially leads to this kind of a figure that you get, that the bottom, if you look at from the apices and you go down, and if you look at what is happening to ventilation, it is going up. What is happening to perfusion, it is also going up. But the rate of change of perfusion is more than the rate of change of ventilation. And if you see from top as you go down, the VQ ratio is going down, and it is reaching the lowest at the basis bottom of the lung. And at the bottom of the lung, you'll find if you're looking at gas exchange, the PO2 is going down, but the PCO2 is also but going up. So this alteration in the VQ ratio leads to a phenomena wherein you say, if you look at just only the bases, the bottom of the lungs or the dependent areas of the lungs are more hypoxic and more hypercarpic. Why does it happen? This is once you understand the carbon dioxide dissociation curve and the oxygen dissociation curve. The blood, when it is passing through an underventilated alveoli, tends to retain its carbon dioxide and does not take up enough oxygen. But while it is passing through an overventilated alveoli, which is rich in oxygen, it tends to give off an excessive amount of carbon dioxide, which is essentially because the slope of this carbon dioxide dissociation curve is linear, but it cannot take up a proportionately increased amount of oxygen, because if you remember, the oxygen dissociation curve is sigmoid shaped, and over there it might be at the flatness, and that is why it is not able to take up an proportionately increased amount of oxygen, which leads to a phenomena that a lung which has uneven ventilation perfusion relationship can better eliminate carbon dioxide than it can take up oxygen. So if you then correlate this, you'll find that the gradient between the alveolar carbon dioxide tension to the arterial carbon dioxide tensions are smaller, because carbon dioxide elimination is more efficient, while since oxygen uptake is less efficient, there is a higher gradient. So the alveoli might be rich with oxygen, but the arterial oxygen tensions are lower, and therefore this gradient between the alveolar to the arterial oxygen pressures are large.